This is the World Recorder. Get John and Carolyn.
Hey, everybody.
Hey.
All right. We're on to part 2, aren't we?
Yes. Part 1 was very rousing.
Part 1 was interesting. Part 1 will make you angry.
Yeah.
I feel like part 2 will have a similar effect.
Yeah.
I think when we're looking at addiction and treatment in this country, it's hard not to get angry about a variety of factors.
Yeah. Well, and angry because it's so absurd and it doesn't make any sense. Mm-hmm. And when things like that happen, you should get angry.
Yes. And as we're going to talk about in this episode, the cost is very prohibitive when it comes to getting better, for lack of a better term, when you are dealing with substance use or alcohol disorder.
Yeah. And also, trigger warning.
Yeah, this is some heavy stuff, you guys.
Yeah.
Addiction, recovery, losing people.
Trauma.
Yeah.
Mental health in general.
Relapse,
empathy.
All sorts of stuff. Yeah, we're going to be talking about a lot. So if you found part 1 to be heavy, which you absolutely have to listen to before you delve into part 2, this is going to be heavy too. But we promise next week we're going to be coming at you with something far less heavy. We're going to be talking about vampires.
Yes.
'Tis the season. So,
and also coincidentally, Jen, September's National Recovery Month. We're almost done with September, which I cannot freaking believe. How is it October? That's insane to me. So I think this is very timely.
Okay. Yeah, I agree 100%. And so, tell us a little bit more about the model of caring for ourselves and how we treat addiction in this country.
Well, with most things in America, the pendulum goes back and forth.
Right.
Back and forth. And I think we're on a very interesting swing right now. But from a holistic model of caring for our bodies, that was really where anything mental health and medicine even started. Tonics, fresh air, retreats, things that said, hey, you're living you went from farm living to the Industrial Revolution, get back to nature.
Yeah.
And then there was this industry that went, we can make money off this. We can profit off the suffering of people and their families. And then you get patient hospitalizations, residential 30, 60, 90-day rehabs, recovery centers, state-based programs, and of course, incarceration, which is the last place you would think is a healing space for recovery.
And with the exception of incarceration, we're not saying necessarily that the other methods that you mentioned are bad. I think they might be overused.
Yes.
Especially when there are alternatives out there. Yeah. But incarceration is never the right place for somebody dealing with substance use disorder.
I don't think so. No. And again, like anything, do your research.
Yeah.
I think for every really great place, there's probably a couple that are terrible, and there's always going to be that. So you have to do your research.
Yeah.
But basically, Jen, the methods and models of care range from harm reduction, which we've talked about a little bit in past episodes. We'll definitely delve into that, to abstinence-only programs and very what's called new age approaches.
Oh, boy.
Yeah. So, but there are, and then again, you have pharmaceuticals to the rescue, because there has to always be a pill for
Of course.
So, addiction's always a topic I found academically and socially fascinating, even prior to wanting to become a therapist, because the equity in what someone is addicted to and how it's managed in their community goes hand in hand.
Yeah.
And I watched the show. Did you ever watch Intervention?
Yeah.
On Annie? I love that show. I don't love that show, but it's an interesting show.
Well, it's like what they did with Hoarders, right?
Yes.
I think it was the same channel.
Similar, yeah.
It's
Annie.
It's for the purpose of making a profit rather than to educate, I think.
Right.
Yeah.
Yeah. And my family did not drink at all. My dad was very anti-substance, and I often laugh that even on his deathbed, he refused to take morphine because he didn't want to become addicted.
Oh, boy.
Well, Dad,
you're on your way out, bro. Have a good time.
That's what I'm going to be like, bring it on.
Yeah.
But anyway, when I graduated with my master's in clinical psych, though, I went on to pursue licensing as a marriage family therapist, and I had a supervisor tell me that if I could go work with families and addiction, I would learn more about psychology and human experience than any other role.
Oh, yeah, you mentioned that.
And I found a private residential treatment center. I'm going to call it Rancho Relaxo.
Perfect.
Any Simpsons fans out there? I don't want to say the name of it. It's actually... in all fairness, it had just started when I started working there. I under Vane's impression, it's doing a lot better things now.
Good.
But I also worked with a professor at USF on a drug, on research on a drug naltrexone, which is an opioid blocker for alcohol. So I always thought addiction was fascinating just because you learn so much about people with it. But other than that, I can't say I'm quite vanilla when it comes to substances. But Jen, do you have any experiences with addiction in your life?
Yeah, not personally, fortunately. I just don't have an addictive personality. But I have actually lost a couple of friends who were battling both substance use disorder, alcohol, and mental health stuff. One of them was death by suicide, and the other was just recently, and that was due to both alcohol and substance use disorder. And both of them, one died under the age of 40 and the other one died at 40. And it was incredibly traumatic. And I feel like, speaking of trauma, because I've had so much trauma in my life, I tend to attract others who have experienced trauma and are in some instances still experiencing trauma or have not healed from said trauma. And so they are self-medicating. And yes, I can relate. And at the same time, I have to put down boundaries. And with both of these people, I knew that they were headed down, for lack of a better term, a bad path. And that they probably weren't long for this earth because they were just they were too deeply addicted. And there wasn't anything I could do. And I think I was probably, from like a self-preservation perspective, deliberately distancing myself because it is incredibly sad. I also believe it's a disease. I'm not looking at them going, God, you could do better. Or why did you die by suicide? That's so selfish. No, I'm just one of those fortunate people who has never been in so much psychological pain that I would rather choose death and not being here. I've never been in so much pain that I just want to drink to obliterate those feelings. So I consider myself fortunate, not better than,
Well, you bring up that point of like, it's either you help and have to bear witness to that, or you have to completely remove yourself. It's really hard to have an in-between. And so, with that said, I think this subject is it's really hard. There's so many sides of it. Because there's the individual. There's the family. There's all the support systems. And then there's even the people within the recovery model who are setting boundaries. And so it's in my opinion, it's the worst kind of, a substance abuse addiction is the worst one to have in America, in the world even. It's so polarizing for everyone based off their experience or their understanding of it, their age.
And people aren't empathetic.
No.
People don't get it. And, watching, going to my friend's deathbed and being told by her family and friends how cold the staff was, the medical staff was, because they knew that the reason that she was dying was, in their opinion, self-inflicted. If she was 40 and dying of cancer, the sympathy would be oozing out of everybody. But because she was an addict, there was no empathy.
And the fact that we're calling that self-inflicted and calling something an addiction, to me, are oxymorons. That doesn't make sense. You can't be self-inflicting something where you're...
And maybe there's something going on with that medical staff too, right? Like maybe they're burnt out. Maybe they're reserving their empathy stores for, I don't know, children who have cancer. I don't know.
You don't have to explain it away, Jen. It was shitty.
It was overall it was shitty. It was shitty for the family. It was shitty for my friend, and it's unfortunate.
But that happened in grad school too. When we did the addiction class, there was quite a lot of people, and even I've had my own feelings with this where I'm like, oh, I can't deal with that. I've said that about pedophiles where I'm like, I don't want to deal with that. And it's hard to hear people talk about addiction in that same light. They're like, well, I can't deal with that. My father was an addict. It's like, well, what a perfect person to be working in this field. You actually do sort of,
but I also get
come
that
in with
too.
a lot of that background too.
Yeah.
So it's the very people who are helping have a very difficult time with this.
Yeah.
So it's a heavy topic. It's a very interesting one for us to be trying to cover. We're going to try and do right by it.
Yeah.
Like Jen said, we covered the definition of addiction in part 1. Addiction is defined as something that brings short-term temporary pleasure and relief, has negative long-term consequences, and that without intervention of some kind, the individual is unable to give up. So, Jen, do you want to read some stats here?
Sure. So 40.3 million people in the U.S. have had a substance use disorder in 2020. In 2020, only 6.5% of people with, we're just going to call it SUD instead of substance use disorder, received treatment.
It's hard enough for us to say things normally.
I know, right? In 2021, about 100,000 people died of drug overdoses, a little higher than that, actually. Black and American Indian or Native American / Alaskan Native folks had the highest rate of fatal overdoses in 2021. And in 2021, approximately 43.7 million people aged 12 or older, 15.6% of the population needed substance use treatment in the past year. However, only 6.8% of them received substance use treatment at a specialty facility.
So do you think we're at epidemic proportions here in America?
Without a doubt. And it's not just the opioid epidemic. Yeah. We live in San Francisco. Fentanyl is big because fentanyl is cheaper than heroin. And because of the people, the faces associated with that addiction on the street belong to folks who are chronically unhoused and typically suffering from mental illness and are self-medicating. There's a real lack of empathy. And I find myself falling into that trap as well. And it's hard to remind myself on a daily basis, because I am confronted, as you are, with this on a daily basis in our streets, that is somebody's child.
Yeah.
And that they didn't ask to be in this position. And they're here because of our favorite word, trauma.
Yeah. Well, we've talked about that before too, in the homelessness and mental health. It's like you kind of, what you see all the time becomes normalized. And it's very difficult from a self-preservation standpoint to have the daily empathy and have to actually go there. You almost have to compartmentalize it.
You do, because it is, I wouldn't say it's vicarious or secondary trauma, but it's painful.
Visually it is.
To see
I think it is.
It is. And I talked about this in the mental health episode, to see a woman walking down Market Street in 45-degree weather with no shoes on. That's awful.
Well, and you can't afford a 3-visit, $600 visit psychiatry appointment.
That's right.
So you're going to go for the thing that is cheap. And helps you not have to deal. And I don't blame you. And, but here's the thing. You can't catch an addiction. This is something that, like you said, there's this picture of what an addict, and when we talked about, kind of the war on drugs, you had that sort of visual of like the bad kid or like the sinister person. It can
lurking
happen,
in the alley.
it can happen to anyone. And I feel that, on some level, all humans deal with some type of addictive thought or behavior at some point in their life. Maybe it hasn't happened to you yet. Families also are fascinating, which is why I got into psychology, because how is it that 2 kids can grow up in the same home? One becomes an addict and usually one doesn't. One usually becomes the overachiever.
One of my closest friends from South San Francisco, her sister passed at age 40.
Wow.
Mom was a severe addict. She passed at 40, I believe. And my friend is 100% sober, does not touch any substances or alcohol whatsoever. Raised by the same person in the same family, completely opposite direction.
And so, probably the older way of thinking was more along like, that's hereditary or, this biology to it. But then that family systems perspective, no 2 children are born into the same family ever. And no 2 parents are the same as their children are born. So, mental health and substance use disorder affect people from all walks of life, all age groups. illness is common, it's recurrent, and it's very serious.
Yeah.
They're also treatable, and many people do recover.
Yeah.
And the coexistence of both a mental health and a substance use disorder, which is referred to as a coexisting disorders, is often where I find it the most fascinating, because you're really, the addiction is sort of secondary.
Yeah.
You got to kind of treat that,
Right.
but really there's something driving
That's
it.
right.
And so I think when we can understand that, and if we're only treating the addiction, you're not looking at everything.
Well, almost everything I watch about homelessness in San Francisco focuses on the drug addiction.
Yeah.
And they are seldom talking about mental health, which is the driving force behind, I would say, the majority of folks
Absolutely.
who are struggling with addiction and living in the street.
Well, and when you take that word addiction and separate it from that picture of the person that we're thinking of as this, unhoused person, dirty on the street, and give it a different face.
Right.
It's the same thing.
Well, it's the opioid epidemic.
Yes.
A clean white kid from Kentucky.
Yeah.
Who developed an addiction after, breaking his knee playing high school football or whatever. I don't even know if you can fucking break your knee, but whatever, and develops an addiction and, dies by the age of 23. There's a ton of empathy for that.
Yes.
Whereas if it's a person of color, and we talked about this in our last episode, or somebody living on the street, that empathy does not exist.
Well, because they brought it on themselves.
That's
Jen.
right.
Yeah.
That's right.
And again, I'm being extremely sarcastic.
Sure. No.
So just so you guys know, a lot of our research came from the U.S. Department of Health and Human Services, the Substance Abuse Mental Health Services Administration. Great information. I'm just saying that there because if you really want to find, we're not going to go deep into, every kind of thing, but they've broken it down by state, by substance, by age, by lifestyle. Like it's actually, these are your tax dollars at work.
It's a huge undertaking.
It really
very
is.
impressive.
It is. I was extremely impressed with their graphs and all this stuff is available to the public.
And I work with the Department of Public Health and I work with the Human Services Agency in San Francisco, and everybody is doing a tremendous job.
I believe that.
With the resources that they have, and everybody genuinely cares and wants to see things change.
You have to do work in that. Yeah. Field.
So please be kind to your civil servants.
Yes.
We're really trying, you guys. We genuinely care.
Let's just be kind to everyone.
Yeah, let's try.
It's a hard world out there now.
Really is.
It really is. And we were talking about how we're adults now. Maybe it's always been this way. We're just having to actually come to terms with it.
It's the latter.
But okay. But I will say there are some general risk factors. There are some patterns. Not always. When you are working with substance abuse in particular. So I'm going to lump them all together because it's never one thing. Never. Genetics. Yes, that will, what they say, kind of loads your weapon, but you eventually pull the trigger. I think a big indicator is the age of onset, though. Did something happen around that time? What mentally, what chronologically, what would have caused some type of maturity delay or some kind of what we call a vertical stress or something in your life. And again, that just because you get divorced or just because something happens doesn't mean your kid's going to be an addict or things like that. But how it's handled and how it's talked about. Right. So again, childhood trauma or traumatic event. Learning and social disabilities are very big ones, though, because nothing calls into addiction more than isolation.
That makes a lot of sense.
And so the opposite, when you think like, oh, their friends are all doing something, like they have a lot of friends. That's cool.
Hey, we didn't even talk about Rat Park, which is the experiment. Oh, you don't know about Rat Park?
Rat Park. That sounds
geez. Okay, guys. So I'm going from memory because I didn't put these notes in. So there was a doctor. I believe it was a Canadian doctor. I think his name was Dr. Alexander. But there were I think it was when folks were coming home from Vietnam. And they were coming home. Many of them were coming home addicted to heroin. And Dr. Alexander, I think, had this theory which went something like this. Again, this is total bastardization of this poor man's work. But essentially, if you had a support system, you were less likely
that makes sense.
to keep the addiction up. If you were isolated and you were more inclined to remain addicted. And so what this guy did was he took all these rats and put them into a very like austere, I don't even know if that's the word, like plain ass environment.
Okay.
And put them like by themselves, I think. And then they were offered either food or like cocaine laced water.
Huh.
And the rats were always taking the coke. They're like, fuck food. I want this cocaine laced water, right?
Yeah.
He changed it. He created Rat Park, this like great place where there's activities, you know, like wheel to run on because you're a rat and other rats. And like it was a functioning, happy community, I guess, from a rodent perspective. Yeah. And the rats weren't choosing the drug-laced water.
That's really cool.
They were like, nope, I don't want that. I've got everything.
I got a
need.
wheel over here.
Yeah, I can run on this friggin' wheel all day and stamp all night. Yeah,
that's really fascinating.
So anyway,
cool.
Rat Park.
Thank
So
you,
it's just
Jen.
kind of
way to lighten up a really dark episode with Rat Park.
I try.
I don't even want to tell you what I had visualizing in my head when you said Rat Park.
I can imagine
a bunch of VA vets. I was like, oh God.
No.
What does some crazy 1950s scientists do?
We've seen a lot of shit in this city, but that's where our mind goes. But yeah, no, it just really supports what you were saying about isolation being a primary factor.
Yeah, and it's interesting because usually people associate socializing with substance use. But, and again, it could go either way. There's no right or wrong. There's often no rhyme or reason. But I will say that learning social disability, and then, of course, any type of dual diagnosis, anytime there's a underlying mental health or even a physical health that's not being acknowledged. Okay. So, Jen, do you think addiction is a choice?
No.
Why do you think most people think it is, though? What do you think that mentality is?
I think our views in the U.S. in particular around drugs and drug use and alcohol are pretty negative. I think it's a limited understanding of how trauma impacts your brain and your choices. I take for granted how much you and I know about psychology and how people react to trauma, and that substance use disorder and alcohol addiction are some of the primary ways people cope. Honestly, I think it's a lack of understanding.
Yeah. Yeah. And I think it's hard to help people understand. I agree with you. I absolutely think it's a disease versus a choice. I don't think anyone would choose to be in that kind of pain. Yeah. And I think that, you know, when you do talk to people in recovery, that's typically the mantra that's talking about, you know, they'll tell their war stories and their heydays and things like that. But an addict's behavior functions around their addiction. It is a mechanism to solve a problem, soothe and decrease pain. It is an endless cycle. It's a pattern and it continues. Yeah. Not just the craving itself, the underlying issue that causes that pain, and which we have just so much clinical research and data and based in mental health and based in science that will specifically, like you said, align ACEs, adverse childhood experiences. We've talked about that so much. I bet we could do a whole episode just on that.
Jeez, talking about depressing.
I know, right? We're not going to do that. But, you know, really the emotional developmental origins. Yes. And often that's, even with mental health, that's often a really key piece, that early trauma, we know it changes the brain. Right. It's going to change the biology of an individual. It's rooted in human experience. And I practice under science and research, but also under the fact that, you know, at the end of the day, we all just want to be loved. There's not one unless you're sociopath.
Well, yes, unless you're wired differently.
But again, I'm going to say, because they're wired differently. Right. It is that also is not a choice. No, that is not a choice either. I don't like the choices.
The neurological
I don't like the things they end up doing. But, you know, so I don't believe this is a question of willpower. Addiction changes your brain. Yeah. And the way that a lot of, especially abstinence-based recovery models, do a lot of thought restructure work when we haven't taken into account how long it takes to have a fresh brain again. Yeah. You know, we know that our brains are organs. They are constantly changing, and if you do, there are some things that cannot be, once it's damaged, it's damaged.
Right.
And, again, although I think our science is pretty impressive, maybe 20 years from now, maybe 5 years from now, that'll be different. But in order to really help someone, having that understanding that any mental disorder that involves changes in thinking, mood, behavior, these disorders affect not only how we relate to others, but they definitely change your impulse control. They change the choices you make. So saying that addiction is a choice is basically negating scientific evidence of otherwise. So if
people do that all the time to support their worldview, alternative facts, bitch.
And again, that's disgusting to be in a recovery model that is selling that to family.
Yeah.
Because basically you're taking that person's only loving support system and telling them, well, this is a choice.
Well, sometimes too, the reason why somebody is an addict is because of their family and the way that the family is presenting to a clinician or a facility. If the factors that drove someone to, I don't know, drink excessively, if those factors, i.e. people, are still present, what are you supposed to do? And what are you supposed to do if the only people that you depend on are the same people who drive you to do like deleterious things to your body for the purpose of mitigating pain? That's the circle that becomes so challenging. And what if your family is comprised of addicts?
Absolutely.
I mean, I can't get into it, but I've witnessed this, and it's like, how are you supposed to be the support system for this person who is in this situation largely because of the example that you set? Yeah.
Well, and that's often the phrase in family systems is the identified patient, or you're called the IP. And in the Rancho Relaxo, when I worked there at the time, it was very heavily focused on the adolescents.
Yeah.
And I remember thinking when I meet the families, I'd be like, well, they all need to be here.
Totally.
Why is the adolescent here? They're the one. I had a therapist who was lovely. You know her. And she'd be like, well, you're the kid who someone takes a shit in the middle of the room.
Yeah.
And you're going to stand up and go, hey, someone took a shit there.
Yeah.
And everyone on your family sitting there going, I don't smell anything. Yeah. What are you talking about? So that kid has to get bigger and bigger and bigger. Yeah. And if you're not going to listen to me, I'll give you something to listen to. It's it's infuriating.
Sense. Yeah.
That's my very weird example.
It works.
But there's a long-standing debate over the nature of addiction and addiction treatment. And this goes back and forth between two schools of thought. Is it a choice brought on by moral foibles? That's a hard phrase for me to say. Or is it poor decisions of the afflicted? Or is it a legitimate illness? Why does it even matter? Yeah. Why do we have to define the why? And kind of go, again, it kind of goes into like, well, we're going very much into the past. What are we doing in the present? Right. And can something be addressed through medical and psychiatric approaches alone? I don't think so. No. Because it didn't come from medical and psychiatric things in the first place, unless it did. Yeah. So we really only obtain the science to prove the genetics and the biochemistry of why one person uses and another doesn't. Cigarettes. I can smoke a cigarette and never smoke one for months later. Yeah. And it's no big deal. Someone else might do that once or twice and they're addicted, so it's very different. And people also have no fucking clue about pharmaceuticals. We talked about this in the last episode. Yeah. Cocaine and many tonics like heroin were manufactured by Johnson & Johnson. Whoopsies. Mm-hmm. So I'm even going to say that a lot of the United States, there's, again, this could be a whole nother podcast. They didn't know any better, or did they? That could be a whole nother thing. Yeah. But, let's go back to how the United States in general manages rehabilitation and recovery. We know it's expensive. Jen, can you guess what the average cost per year for a recovery program is in the United States or a rehab?
Oh, God, I imagine I guess they vary in terms of type, but if you're doing a live-in, like the one you were at, Rancho Relaxo, I'm assuming it's at least 10, 20K a month.
At that time, it was about 30K
a month. Yeah, that makes sense.
And so, and that was a fancy private one. So the average cost of a drug rehab, and so where this data was taken from, these are probably state-run programs.
Yes.
Is about $13,500 a month.
Yeah.
So the cost of the cheapest medical detox program is about a little less than $2,000 per month. $6,000 per month for the cheapest inpatient rehab program.
Wow.
I'll explain what those are in a bit. The cost for an outpatient rehab, this is what standard practice is, that you should do a 30, 60, or 90-day program.
Yeah.
Depending on your insurance, you're not going to be there for less than 5. And like I said, where I worked, it was about 30K a month.
Okay.
And I was floored at that. People were giving us checks for that shit. And I remember my coworkers and I were fresh out of grad school, and I was like, I'm holding a $30,000 check right now. This is insane.
Yeah. Yeah, no, that's nuts.
Half of why I wanted to work at that job is because I got free breakfast, lunch, and dinner whenever I worked there. I was like, this is cool. Well, and I got paid $20 an hour.
Well, yeah, that makes absolutely no sense.
Yeah.
Like they're using people fresh out of grad school or people who need hours.
Yeah.
And they're probably dealing with, no offense, like young people who
I had no idea what I was doing.
A much higher level of experience in order to treat these issues.
They left out the 4 friends that I have. We are still friends to this day.
Yeah.
Shout out to Baba, Alex, and Lauren, and several others. The bond that we made being traumatized at this company and even with our poor patients, they lucked out because we went to a good grad school. We had great boundaries. We had a phenomenal supervisor.
Yeah.
I lasted a year. I left because I refused to do some unethical things that I thought were unethical.
Yeah, I remember this.
The timeline, though, was about a year for turnover.
Yeah.
And you just got burnt out. The paperwork alone burned me out.
Makes sense. So, and that's a private place. That's not even state-run where you're dealing with Medi-Cal and shit like that.
Oh, terrible. So there's so many variables, Jen. You just kind of talked about. We talked about state-run versus private. There's a lot of variables that influence the cost of rehab, including health insurance plans, how intensive the treatment plan, and kind of what the specialty is too. The cheapest rehab centers are always going to be state-run facilities, and the trade-off is a longer wait time, limited treatment program compared to privately owned facilities, which will kind of just let anyone in. I don't mean that. If you have money, they're ready to
money
take
talks,
you.
man.
Money talks.
Yeah.
So I talked a little bit about, several names. I want to give you some insights here. And you may know some of these things, but I'm curious if any of this is new. So the recovery models for rehabs, there are thousands of what's called a drug abuse rehab program. And this offers addicts a variety of treatment approaches, from traditional, which means evidence-based care, to more experimental, holistic services. This is the place where you're going to have more kind of the quote new age stuff, which I actually thought those were the kids always loved that better. When it was sound bath time or drama therapy time, they were all up for that.
I love that.
Yeah, no, it was amazing. And then it was like, here, come in for your CBT session. They were like, do I have to? And I'm like, yeah, because I told your insurance I was going to do this 3 times this week, but just come on in and sign the paper. We took some liberties there. Oh yeah. So from private to community-based, there's these tiers. So a residential is going to be a 1-year program. This means it's inpatient. Treatment is specific. They're usually hospitals, medical clinics. This offers detox. So this is someone who's, I would say, really medically needing intervention to safely detox off things. Or there's some other coexisting disorder or something else going on, or there's been maybe suicide attempts. So that's an inpatient program. What's called an outpatient residential is maybe a couple hours a week, slightly less, and you can live at home. Then there's something called PHP, partial hospitalization programs. So let's say someone comes in, a parent has a daughter who's having some eating disorder. They might come to me and say, hey, we want her to go to a therapist, I'll assess. And then I'll say, you know what? You're not quite ready for what's called outpatient private therapy with me. I want you to go to a PHP program. I want you to get some specific skills. I really want you to be assessed through 6. I want the family intensively there. Think of me as the lowest step down. So there's some great PHP programs here, and I actually really like what they do. So it's about 20 hours a week. You usually can live at home, go to school, and then you also have something called intensive outpatient, which is maybe 10 to 20 hours a week. This is great for teens. a lot of evenings, weekends, so you can work and do whatever you need to do, which makes sense. So, and then of course we have medications for addiction treatment. I have mixed feelings about this. A lot of individuals with physical dependency on certain substances like alcohol, nicotine, opioids. There are medications and of course heroin and meth and all these things that can kind of help you sort of drop down your tier. And then there's where I'm in the post-treatment model. So this means continuing care, follow-up, support plans, tools, really how are you going to successfully exist in the real world? Yeah. Think of this like your recovery program. So individual counseling, group counseling, and education services, vocational services, life skills. Yep. Family services often get told the addict is the identified patient. They're the one that needs to change. Got it. I love when there's family services involved. Yeah. There's also a lot of different step down services for recovery, like sober houses, sober dorms, even for teens entering college. Yep. Recovery high schools. Didn't the Y have a recovery high school as part of Embarcadero?
It wasn't a recovery high school necessarily. It was a it was a great idea. It was called Youth Chance High School. Okay. And they didn't have many students. I don't think it was specific to recovery, but it was credit recovery. Okay. I think. But yeah, shout out to Youth Chance because I got to work with them around workforce development a little bit when I was at the Y. But yeah, but not specific to recovery from substances. Okay. Yeah.
And then of course, what you're going to step into the most commonly thing that we talk about, which is kind of what we've been setting up for recovery support groups. Yeah. AA, NA, 12-step program, something called SMART, which is usually what I refer people to, self-management recovery trainings. Yeah. Jen, talk a little bit to me about the different paths of recovery that are out there that people tend to, again, we can't talk about every different treatment model, but what did you find?
So, I listened to this podcast called Last Day, and that really changed my perspective on abstinence-only treatment, which seemed to be, and you can tell me, seemed to be the primary approach. Actually, you don't need to tell me because the research I found says it's estimated that about 95% of treatment programs are abstinence-based. So this podcast I listened to, it was a woman named Stephanie Whittles Walks, who's the host of this podcast and sister of the late Harris Whittles, who was a comedian, writer, producer, actor. I think he was on Parks and Rec, I think. He died, unfortunately, in 2015 of a heroin overdose.
Oh, I didn't know that.
And in this podcast, his close friends, Sarah Silverman, Aziz Ansari, they join Stephanie as she introduces the concept of the show and why it's critical that it exists. And a lot of the focus of this particular podcast is on abstinence-based treatment and why it's ineffective for so many. So I'm not going to cover all of the reasons why this approach doesn't work for everyone. It does work for a lot of folks. It just doesn't work for everyone. Nor are we going to sit here and shit on abstinence-only treatment because, again, it does work for a lot of folks. We just want to point out that we can't have a one-size-fits-all approach to treatment because everybody's trauma is different. Everybody's brains are different. So, this is from rehabcenter.net. Critics of abstinence-only programs believe that it can be exceedingly detrimental to kick an individual out of treatment for relapsing, leaving them stranded without the help they need at such a crucial moment. Some may struggle with the concept of admitting that they are powerless over a substance, which may make it easier for them to relapse. Alternative perspectives teach individuals to become empowered with education and treatment about treating their substance abuse and mental and emotional health concerns. What's the AA, like the prayer or whatever? The
Serenity Prayer?
The Serenity Prayer?
God, grant me the serenity to
the things I cannot change
and the wisdom to know the difference.
Right. Something like that. So to me, that's like, hey, I have no power.
Yes.
All the things that I can change, can't change, whatever, I think a lot of people struggle with that. Some people feel that these programs infringe on an individual's well-being, citing that the methods employed are often confrontational. These approaches could be potentially damaging to elderly or individuals that have suffered abuse. So, not every individual, another problem, adheres to the practice of understanding a higher power.
Yeah.
Or the understanding that there is a higher power, rather. That's one of the big issues I have with AA in particular. Now, I don't know if this is still the way they do things, but the Serenity prayer is a prayer to God, and as an atheist, I think I would struggle with that. Today it's becoming increasingly evident, as you've pointed out, that addiction and abuse are rooted socially, physically, mentally, emotionally, and spiritually within a person's life. Thus, for recovery to be wholly successful, I think it has to attend to the drug or alcohol abuse and address the following concerns related to substance abuse. You talked about all this stuff.
Yeah.
Family relationships, jobs, education, mental health, legal concerns. And I thought that this quote, really resonated. If there's anything modern research on recovery is teaching us, it is two critical lessons. People with alcohol and drug problems, even the most severe of such problems, are not a homogenous population. And there are many pathways and styles of long-term recovery. This comes from William White, who's not Walter White, William White, who's a researcher. So, I think that this reliance on abstinence-only treatment, though I think there's obviously a diversity of treatments out there, but when I read a stat that 95% of treatment programs are abstinence-based, maybe we need some different approaches.
Well, I think that's, everyone, I think that's a good way to look at mental health in general.
Yeah.
That I think these models, the models are cool. Yeah. I love them. I love them for academics, but you're dealing with humans. And a model, I think models really look nice on paper, and I get how we have to prove, and, if you can't measure it, you can't this, but, we talked about all the different factors that, shame, biochemistry, social circumstances, how your family life, you and I have had experiences in this.
Yeah.
There never is a cookie cutter.
No.
And just when you think maybe it is the cookie cutter, but it comes in, you have those ones where it comes in lots of different sizes.
Yeah.
Maybe that's what it is. And then it's okay to go outside that. Like maybe the model is there isn't a model because everyone's unique and we have some structure and some format.
Right.
But it makes me think about, okay, so is there any hope for the future? Right? Like what the hell?
There has to be.
And I think that, this was another site that I found that again was just filled with great data, National Institute on Drug Abuse. Great website, tons of stats. I loved what they talked about because it actually made me feel really positive. Yeah. What we're seeing right now from legislation, politics, a lot of professional organization is, hey, what we're doing isn't working.
Yeah.
It makes people feel more shame. It creates a hierarchy where I know more because I'm sitting here, even if I am in recovery, and I'm here and you need to get here. Yeah. Well, if you already have shame, low self-esteem, like you're not feeling like you feel like shit. Right. Now I've put you in another world that you have to seek perfection and some type of idea. And I don't know that always works. So neuroscience, how do drugs affect brain circuits? How does addiction occur? Brain imaging, genetic research, addiction science, something called neuromodulation therapy, polysubstance use addiction, and brain circuitry. So tons of funding for that. Prevention research. From a public health person, let's stop dealing with what's happening after the fact and go, well, where did this start? We know where it starts. In your family,
that's
in your home,
really
and I'm not even going to say your family because that sounds so heteronormative. Your community. What's going on in your community? Development of testing new therapies to treat and prevent overdose, evidence-based interventions that are going to help address community needs and the impact of structural racism in addiction and addiction research. Yeah,
no, I think that's key. And where I really struggle with any hope and change theories, although I believe wholeheartedly that there is hope. I think I'd be very depressed if I didn't believe that there's hope, is that I see underlying all of this an inequitable system predicated on
You can say it ugly, Jen.
I mean, keeping people poor and keeping people addicted.
And absolutely.
And
the whole insurance model is predicated on people keeping people sick.
Yes.
And preventing the very people who actually want to go serve them.
Right.
The reason I left a Medi-Cal program that I believed in intensely was because I was so sick and tired of meeting with my client 1 hour a week and spending another 12 hours writing a treatment plan that I had to fax. It's infuriating.
Either the intentions are good, but the bureaucracy around it make it difficult to actually give meaningful treatment, or the intentions are fucking dirty. And it's all about, maybe not all about, but it's dirty in the sense where the more money you have, the quote unquote better treatment you're going to receive. The better access you have.
Yeah.
And I think, I mean, I'm not a big fan of capitalism the way we do it to begin with, but when it when it completely controls our healthcare systems,
it does.
Then I don't believe that I'm going on a rant, and I shouldn't because we're at the end here. But I firmly believe that money and medicine do not and should not mix,
and they're completely in each other's pockets.
They're enmeshed.
Yes.
Yeah.
No,
anyway,
you nailed it.
Fucking sacklers.
I know, right? Well, and a lot of the drugs, naltrexone, one of them, it's going to ruin the rehab industry because it's basically saying, well, we can use some pharmaceutical to help you not think about
or
this.
Suboxone, right?
Yes.
Is that what it's called? And that's what they talk about in that podcast I mentioned. It's like this person was functional. They were taking Suboxone. And this is her brother that she was talking about. And he missed an appointment. And there was a very valid reason why he missed an appointment. But they said, you missed an appointment. Yes. You're done. No Suboxone for you.
Yep.
He went out and he got heroin. He fucking OD'd.
Yep. And the best models with this is when you combine that with talk therapy.
Right.
And more importantly than talk therapy, with social support and outdoor. And so, we're preaching to the wrong people.
Anyway, if y'all are mad, we're mad too.
So speaking of that, having different innovations and entrepreneuring startups, telehealth, outdoor spaces, things that help interventions actually combining physician pharmacist collaboration, mental health, any disciplinary justice, social justice initiatives, harm reduction, racial inequity. There's, again, we have mixed feelings about how well this money is going to actually go to people. But we are seeing more funding for some, the racial inequity initiative that received over $100 million this year. It probably needs way more than that.
Yeah, but that's a good start.
It's a good start. And I don't want to shit on everything, but I love this 2018 Cornerstone Recovery quote. Ancient addictions, they said, it stands to reason that once man discovered the euphoric properties of mind and mood-altering substances, human nature's proclivity for excess meant that it was shortly thereafter taken to extremes. This is a really great article. We'll post it in the show notes from Cornerstone Recovery. But, we all have different relationships with, like I said, some type of thing, whether it is a substance or whether it's a behavior or whether it's a person, that we will find use, abuse, and addiction.
Food.
Anything. If you can name it, if you can buy it, you can be addicted to it.
See how many shoes I have in my fucking closet.
Mine's my shoes, I know. So like most of the episodes we do, it's never just one thing. There's always an anthropological reason. There's always a social reason. And there's usually an inequity in how we view it.
Yep.
And so, when it comes to things like this, it makes me very angry. It makes me very, I think you and I have both been fighting back tears throughout this episode. And I hope I try and use that anger and that frustration to do better.
Yeah.
And even if it's just me sitting in that chair or holding that space and going, I don't know more than this person. I'm just going to hold space with you.
Yeah.
And you don't owe me anything.
Yeah.
And I don't want to say I don't care what you end up doing, but I want good things for you.
Yeah. Folks, it's not incumbent upon you or Carolyn or I to solve this problem. This is going to take the entirety of a systemic change. But there are things you can do, right? If you want to know more about this, read up on it. Carolyn has given you some wonderful resources. We're going to put some great resources in the show notes just by virtue of understanding how addiction happens in the first place. And not only understanding, having empathy for someone who is struggling with substance use disorder or alcohol addiction. You're making a difference. And if you have people in your life who are going through this, be empathetic, have your boundaries, and educate yourself on how all of this works. I mean, that's a simple starting place.
That's all you can do.
Yeah.
And
that's all a lot of us can do.
More than enough.
Yeah.
And that's more than enough.
Yeah.
And I applaud you, and we hope you all are well and taking good care of yourself.
I mean, that's all we can do. So.
That's all you can do. And so, what is that? Take care of yourself, or Jerry moment. Take care
Take care of yourselves and each other. It was like the opposite of that. That was ironic. Anyway, so we hope you enjoyed this two-parter. We know it's been really heavy. We promised you that we're going to bring you something incredibly light next time. I'm going to wear my fangs for the occasion.
Interesting.
Maybe I do have fangs. We'll get into.
I'll wear my vervain.
Oh, perfect. Then I can't compel you. Wow, we're going down the dork rabbit hole. I feel like we need some levity. Anyway, you guys, like, subscribe, give us a good review, and we hope you enjoyed, and we hope you're able to, help yourself. Help others, but be kind, take care of yourself first and foremost, right? You can't help somebody else until you ensure that your needs are met.
Absolutely.
And that you're in a good place. All right.
Hey.
All right, everybody. We'll see you next week.
Bye.
Bye.